Welcome to the next session of our webinars on emergency health workforce policies to address COVID-19. I'm Ed Salzberg, a senior researcher at George Washington University's Fitzhugh Mullen Institute for Health Workforce Equity, and I'm the moderator of today's panel on increasing the supply by tapping retirees and other health practitioners. The number of Americans infected with the coronavirus is growing rapidly, from a few cases in February to more than 250,000 cases and 6,000 deaths in America, with some projections being that there will be more than 100,000 to 240,000 Americans dying over the next several months. Our elected officials, our healthcare leaders, our health practitioners across the country are struggling to assure that the nation has the capacity to treat all infected patients effectively with the best available tools and knowledge. Our healthcare system is being challenged as never before, and it will get worse in the coming weeks. Our leaders are scrambling to increase the supply of beds, of ventilators, of masks, of tests, and they're desperately seeking ways to increase the supply of caregivers to treat those in need. This includes not only doctors and nurses, but respiratory therapists, mental health providers, health aides, and many others. Today's webinar is focused on promising strategies to address the surge in need by tapping retirees and other practitioners who may be available. Can retirees help fill the gaps? Can health workers in settings or occupations where demand is temporarily down, can they help out as well? This includes clinicians who may be from private practices or school nurses or others. Are they a resource that can be tapped? What needs to be done to tap these potential resources? What strategies hold the greatest potential? There's little time to develop, train, and prepare these workers. They are urgently needed now. We're lucky today that we have two of the top experts in the field, both of whom are actively working on everyday basis to try and identify strategies for states that can help increase the supply of the capacity and to do so quickly. We'll first hear from Lauren Block from the National Governors Association. Lauren serves as a program director for the NGA Center for Best Practices Health Division. She focuses on issues related to health workforce, rural health, health insurance coverage, and data. Most importantly, she's leading the NGA effort to work to share strategies surrounding health workforce responses regarding the COVID-19 epidemic. Prior to joining the NGA, Lauren held several roles at the Center for Medicare and Medicaid Services. Our second speaker is Jean Moore. Jean has been the director of the Albany Center for Health Workforce Studies for over 15 years. Jean also has real-world experience as a caregiver as a clinical nurse specialist. She has been involved with New York State, working with Governor Cuomo's office to help develop and implement strategies in New York to build the workforce capacity in this crisis. Let's hear first from Lauren regarding the NGA and what the NGA is finding. Lauren, what are some of the strategies that states are using that seem to be most promising?
Thanks, Ed. There are several different strategies that we are looking at helping states. States are taking a variety of approaches to addressing the workforce through executive action, including executive declarations and executive orders. I'd say the thing that we're seeing the most is surrounding licensure. In most states, healthcare providers have to maintain licenses in each state in which they render services to patients. But there are opportunities for states to allow temporary waivers or licenses so that providers can practice across state lines via telehealth or in person. In addition, states can think about ways to make it easier for those who already have licenses to maintain them by easing those in-state licensure requirements. So that can involve suspending regulatory provisions related to recently lapsed licenses, extending deadlines for continuing education hours, accelerating licensure for people who just finished school, and expanding credentialing to allow providers to practice in multiple facilities. That last strategy may be more around the health facilities. And these approaches are relevant for not only physicians, but also for many other types of providers. Second, importantly, is telehealth. That's surrounding coverage, provider participation, the originating and distant sites, and considering the new DEA guidance surrounding substance use disorder. So it's important that telehealth services can be offered within and across state lines. Third, I would focus on scope of practice. This is a big strategy that many states are pursuing right now to expand the pool of clinical healthcare workers, everything from respiratory therapists to APRNs. And that's about authorizing temporary extensions to scope of practice for reimbursable services, reducing supervisory requirements, and letting providers practice at the top of their license. In addition, states are looking to use volunteers. That includes both clinical and non-clinical individuals. And for those individuals who were licensed, again, thinking about how to simplify the processes to get them to be able to practice and ensure the appropriate liability protections. That's very important with addressing licensure in general. Retirees, I know Jean's going to talk about this in more depth, but reactivating licenses for retired clinicians who retired in good standing. And it's important to consider there the appropriate roles for high-risk populations and what's appropriate for them to do. We also think about the essential personnel outside of hospital walls. A lot of the conversation focuses on the hospital, but there's also the other facility-based care, like where long-term services and supports are delivered, and services in the home with personal care aides and home health aides and others, as well as EMS. All of those folks need to be supported alongside the rest of the health workforce, and we need to think about the personal protective equipment and other issues for them as well. We also think about the physical and mental health of the patients and providers. A number of states, and it's been growing, are requiring or encouraging the cancellation of all elective and non-essential procedures right now to be able to maintain the PPE that currently exists and to protect the health and safety of those in the facilities. Also, important to identify strategies for childcare for essential workers. Many states are starting to take more approaches there. Also thinking about taking greater precautions within healthcare facilities by prohibiting visitors and non-essential personnel. Of course, there are certain exceptions, for instance, with maternity as well as end-of-life care, but to really do that and to help reduce the spread of the virus. And also giving EMS workers the option not to transport certain patients if they deem it unnecessary. Mobilizing students who are training in the health practice field also is important if there is sufficient PPE to let them practice to the extent that their training or license allows. Where there isn't enough PPE, we have definitely seen that students are being sent home, clinical rotations are being canceled. So that obviously makes sense. You need to protect the health and well-being of everyone, but it is worth thinking about what is within the existing authority for governors, boards, and training institutions, and where they might need to look to accrediting bodies as well to figure out what might be possible so that those individuals who are currently in the pipeline have the ability to contribute to the workforce and to finish their education, whether that's graduating early or practicing to the extent of their existing training. Credentialing veterans and foreign trained providers are other strategies, and that includes identifying strategies to credential recently transitioned veterans who hold military medical certifications that have equivalent civilian certification, and leveraging the skills of foreign trained healthcare providers who are not licensed in the United States by temporarily waiving or modifying requirements to practice. And then beyond the workforce itself, there's the actual physical space that we need to think about, and how states are using what are the existing restrictions, perhaps on bed limits or types of services that can be provided, as well as field hospitals and reporting requirements for those facilities. If we could just go to the next slide quickly. I did want to mention that in addition to the healthcare workforce specific priorities that governors are paying attention to, some really key priorities are around personal protective equipment, as I mentioned before. In order for the healthcare workers to do their jobs, they need those protections so that they can stay healthy. Ventilators, obviously, are critical, and as well as testing. And also, many governors are imposing social distancing requirements right now as well. And our website has memos on several different issues, including healthcare workforce and facility capacity, among other issues. So I would encourage folks to take a look there. there, and includes many state-specific examples of the concepts about which I discussed. Thank you.
Thank you, Lauren. Appreciate that. A quick follow-up question before going to Jean. What are some of the major barriers that states are facing as they try and introduce these strategies?
Sure. Well, as I mentioned, I think the biggest barrier that states really are facing is that, well, first of all, everything is moving really quickly. It's changing really quickly. So that is a challenge, but there are the ancillary issues that are critical to the successful delivery of healthcare surrounding the personal protective equipment, testing, and ventilators. Those obviously are really critical to make sure that the healthcare workers are able to do their jobs.
Thank you. Now, let's go to Jean. Jean, in New York, Governor Cuomo has been very aggressive in asking retirees and others to volunteer to assist in the pandemic. I think the latest figure is something like 82,000 or more individuals have volunteered or offered to assist. How is it going, and has it been effective so far?
So I would characterize this as a work in progress. And what I'll do is talk you through what's being done, where we are, and where we're headed. Could I get my first slide? Thank you. So one of the things that's happened, and I think everybody's heard an awful lot about this, is that early on there was outreach to retired or inactive health professionals. That was followed by outreach to all licensed and active health professionals. And finally, health professional associations who represented specific health professions like medical societies or the CRNA group, et cetera. And Ed, you're correct. Over 80,000 individuals have responded so far. And a lot of what's happening right now is vetting these candidates and actively working to deploy them in facilities that have great unmet need for workers. Another activity has been outreach to New York's health professions education programs. And actually, it's not just about contributing to surge capacity, but also being mindful of the need to maintain the educational pipeline. So the outreach encouraged faculty, staff, students as available to, help with surge capacity. But also there was great encouragement to get programs to assure that students complete required clinical training, which, as Lauren pointed out, has really become a lot tougher as health facilities are less able to accommodate students in the usual format. So I think there have been efforts to try to be more creative in getting students to complete educational requirements. And for instance, using simulation labs or a mentorship model for completing clinical training, and also encouraging early graduation of qualified students and using that as an opportunity to deploy them into the healthcare delivery system. Next slide, please. Another area that the state has focused on is regulatory flexibility. And again, as Lauren pointed out, there's an awful lot going on to try to assure that people who want to contribute to surge capacity can easily be relicensed. And also recognizing the licenses of physicians and other health professionals from other states to practice in New York, which provides great support for telehealth strategies. There's also been some change to scope of practice requirements, and a couple of examples I can give you. Less restrictive supervisory requirements for CRNAs, physician assistants, nurse practitioners, and also the removal of limits on working hours for physicians and residents. A lot of the regulatory changes are actually available in summary form on the State Education Department website because they are the ones who have to roll out these changes. Next slide, please. So the New York Center has a Health Workforce Technical Assistance Center supported by HRSA. And we've actually built a resource on the HWTech website on COVID-19 and the health workforce. We're trying to find a place to put all of the resources that are out there in one place so it's easier for people to find. Thank you.
Thank you, Jean. A follow-up question. Is there a role for individuals who may be older and vulnerable to the virus, who've been out, or individuals who've been out of the workforce for several years? I'm assuming that the state is screening the volunteers, but beyond that, is it recommended that people who, again, who may be a little older or more vulnerable, are they being encouraged to volunteer as well?
So, you know, again, Ed, it's clear that there was great outreach to people with inactive licenses, people who have retired. And I think there's been mindful effort to recognize that they can provide help, but in more supportive roles. You know, again, assist those on the front lines and create more efficiencies to do what they need to do. An interesting thing that happened was that a number of mental health professionals volunteered, and they are actually being deployed to staff an emotional support hotline. So again, I think there are a lot of strategies that really take into account the fact that we certainly don't want to put people in harm's way and find ways for them to help.
Jean, in terms of those mental health counselors, are they able to volunteer from their home, or do they have to go into the hospitals, or are they actually able to work any place where they are?
So I don't have precise information about that, but my suspicion is that they are, to the extent possible, being able to work remotely. And again, to Lauren's point about telehealth, I think more and more we're going to head in the direction where providers and patients can communicate and share information, but in different locations. So I think we're going to see a lot more of that in our future.
Well, that's encouraging, because that would mean that in this crisis and the urgent need for capacity, that people could contribute, in fact, wherever they are by supporting the effort. One last question on this here, Jean. What information should a state be collecting from individuals that want to offer assistance?
So I can tell you the sorts of things that New York collected, obviously starting with what health profession do you represent? Are you licensed? The last time you practiced? Availability. Are you able to help? When can you help? Where could you help? What kind of services could you provide? Do you speak any second languages? Prior experience in infectious disease, emergency room, ICU, CCU, working with respirators, and also logistical needs, need for childcare, need for transportation, need for lodging. So trying to ask some key questions that could make it a lot easier to deploy to high-need hospitals, knowing where people are, what they can do, their availability, et cetera.
Thank you, Jean. Let me turn back to Lauren. Lauren, in regards to the subject of licensure, what do you think what are the key issues states need to be thinking about in regard to licensure?
Sure. So as I mentioned before, obviously having reciprocity, just letting providers practice across state lines can be helpful. Some states have taken the approach of expediting licensure, meaning you still need the license in the other state. They can certainly waive fees for that, but expediting is better than obviously the normal timeframes. I will note that there are states that participate in interstate compacts for certain professionals, which do have varying benefits. The nurse compact, for example, allows participating states, and I believe there are upwards of 35 states participating in that nurse licensure compact, and that allows licensees to practice across state lines fairly easily. Some of the others, they all operate a little bit differently, but that is something that is definitely helpful. There are also several other levers that states can leverage, like the Emergency Management Assistance Compact, also known as EMAC, which is a multidisciplinary mutual aid compact whereby upon the governor activating, so gubernatorial activation, states can receive assistance from other states. So that can also solve the problem of liability and responsibilities of costs and allowing for credentialing. And so and then can let providers practice across state lines. So even though all the states participate, it does have to be activated for use. And an increasing number of states are activating EMAC. Also, there is the Uniform Emergency Volunteer Health Practitioner Act. I believe there are 18 states that participate in that, and it has model legislation, and that upon registering, that allows healthcare practitioners to volunteer during a state of emergency as well. So those are a couple of different ways that states can take action, but really many states already have at least taken some level of action for one, or in many instances, many different types of providers. Jean did mention several different types, all of whom are critical to response.
And you said that the NGA has guidelines or guidance or information on all of this on your website?
We do. We have a memo that should be updated very soon. It's publicly available on our website. If you look at our COVID resources, we're covering a lot of different issues and providing state examples. We also link to different associations like the Federation for State Medical Boards, as well as the other profession-specific associations who are doing state-by-state tracking surrounding waivers of licensure, telehealth, as well as looking at retirees and scope of practice issues. So a lot of those individual associations are staying up to date day by day, and we're linking to their information.
That's great. That'd be very helpful. We've tend to focus on directly on the urgent needs of people in the hospital with acute needs. Are there other health workforce needs that you're seeing beyond the hospital?
Sure, certainly. So there are long-term care facilities, certainly, and home-based care. We're also focused on other vulnerable populations, looking at individuals with disabilities who may have mobility issues as it is, as well as homeless populations. So we are looking more broadly at different populations. And also, as Jean mentioned, we're looking beyond COVID-19, right? So there are the mental health needs of both people in the community who may be experiencing challenges as a result of what might be social isolation for them, as well as for the healthcare providers who are being put in difficult situations, working long hours, who are the most critical to the response effort, and making sure that they get the supports they need. So a lot of states have taken action focused around delivering telehealth services that are not only related to COVID-19, but so that people can have that continuity of care, whether it's students who left universities and needs mental health supports from their providers across state lines, or somebody who has a chronic health condition that can be supported and treated remotely. And as Jean mentioned, in terms of keeping some of the high-risk individuals who may be retirees or formerly inactive, thinking about how telehealth can be used as a support is critical for those individuals who are reactivating.
Great, thank you, thank you. Let me turn to Jean again. Jean, are there other strategies that New York State is pursuing to increase capacity to meet the surge in need?
So there's an interesting phenomenon that I want to mention, because I don't know if it's happening in other states, but I think it's noteworthy that upstate facilities where the pandemic is not quite as severe, who have, facilities that have canceled elective surgeries and really minimized service provision, there's actually some furloughing going on. And so providers in certain areas are not being used, and again would have the potential to be deployed in ways that would make a lot of sense to meet the demand for services. So that is just now happening. That is something that we're hearing about fairly recently, and again, clearly there's got to be some thought to how to deploy them and use them to help with the surge capacity.
Jean, also, as other states are in an earlier stage than New York, what advice would you give other states based on the experience in New York that you've seen so far in terms of recruiting retirees and others? I know it's early, but are there some lessons learned that might be helpful to other states?
Sure. So you have to have a plan, and a plan that involves collaboration. I think that the thing that struck me the most in New York was efforts that were underway crossed the state agencies as we figured out how to do the outreach, what to do with the volunteers as they were showing up, how to deploy them. So it started with collaborations among state agencies, and then it broadened. It broadened to professional associations, healthcare associations. So, I think, the governor talks about the fact that, look, we're all in this together. We're one state and we've got to shoulder it together. I think that's a key to success, that, we kind of put down our turf issues and work collaboratively to figure out a way to get this done as rapidly as possible, because we just don't have the time to do otherwise.
Do you think, in fact, there's a question for both of you, do you think there's any chance that since the surge is happening at different times in different states, of some of the experience and some of the practitioners that go through the surge in an early state could be used in some of the states? Are they sort of almost a roving core of caregivers? I mean, it sounded like that, in fact, when Governor Cuomo said, if others help us now, we will help them later. Do you think it's something that could happen, and how might we sort of foster that?
I can start, Jean, yeah, I can start on that one. I would say that the steps that are being taken now via executive orders and other actions certainly are facilitating that potential for that, with the ability for cross-state licensing for whether it's in person or it's virtual, for there to be able to be that kind of movement. So absolutely, we are set up for that. And I believe also, things like the EMAC allow for that as well.
I also think that we've got to think mindfully about how we learn from this. I think that after 9/11, we said, okay, we really have to be prepared. And we tried to be prepared, and then life got in the way, and perhaps we lost track of some of the things we had committed to doing. It's clear to me that we have no choice but to learn from this experience and build strategies and approaches that allow us to respond to something like this a whole lot more quickly, a whole lot more efficiently. And again, to Lauren's point about, can we pull together some lessons learned that cut across state lines that could be adopted? I think that that's important for us to do.
One closing question. Again, given that there are a range of options a state can consider. And given that other states are not not yet at the point of surge, are there some priority things that you would recommend? What's sort of the first early things that they need to do to be prepared and to help build the capacity? What would the priorities be?
So I can start on that one. I think the biggest thing, and again, this is something that states have already started to do, is to think about temporarily creating new administrative flexibilities. Again, that's happening with streamlining the licensure, thinking about continuing education. What can you do to remove the barriers for participation among providers who are active or inactive to really be able to participate and focus on the critical needs? That I would say is the biggest thing, and is cross-cutting across the various issues.
I think that there's a certain urgency on the acute care side of things, and I think that as states increasingly recognize what they face, I think that knowing who's in your workforce, knowing the way in which cases are expected to play out, I think understanding what your current hospital capacity is to care. So I guess what I'm saying is I think we need to do some on-the-ground planning at a state level to figure out what have we got, what do we need, and how do we get there? And again, I think it will occur differently in different states, but nonetheless, any state now has got to be asking those questions and trying to find good answers.
I want to thank both Lauren Block and Jean Moore for their presentations. I also want to thank you both for the important work that you're doing, and wish you luck in your continued work on this critical issue. And final comment, the slides that we used today, as well as additional references and resources, will be posted on the Mullen Institute website for the webinars. And as the speaker said, both the center in Albany and the NGA have resources on their website, and individuals are encouraged to go there for more information. Thank you both, and thank you.
Thank you.
Thanks.